Recording. Okay, so just bear with me 1 second. Okay, we have a format that we like to follow. Okay, so hello and a very warm welcome to this discussion. My name is Joanna Taylor and I am Laura's marketing and communications person.
Accountability buddy,
Yeah,
friend,
yeah,
partner
very
in
good friend.
crime.
Yeah, partner in crime, absolutely. I've been working with Laura for a number of years now, and I also work with other healthcare brands like Noi Group, La Pub Scientifique, Lorimer Moseley, Master Sessions, Pelvic Pain Matters, and I've been working with those for about 20 years. So I do the same for all of those different businesses. And I am here to help Laura build her business and communicate her amazing messages with her audience, and just to keep her a little bit accountable as well, which we have a lot of fun doing, don't we?
Yeah, we do. We
Okay, so
do.
I'm absolutely delighted to be doing another one of these webinars with Laura. We did some earlier in 2026 and they were amazingly successful. And we are back for another series. And you can find all of her previous sessions on her YouTube channel. I've dropped the link for that into the chat. So please do click through, like, subscribe, share with your colleagues and friends, and check out some of the other amazing content that we've produced. So Laura is a pain specialist, clinician, and mentor to healthcare professionals worldwide. She brings a unique perspective, combining cutting edge science with compassionate and inclusive practice. So, Laura, I know you hate it when I say that, but we
Honestly,
have to say these things.
the worst bit of the whole process is the introduction. Like, but yeah, but
You're
it is
so
important.
humble. That's why
No, but
you
it is.
have me.
Yeah, but it is important. I get it, and it's
Yeah,
partly why like it's really important that you introduce yourself because I want people to know that I don't do this alone, right? I think
yeah.
there's too many people out there who are like the front of their what they're doing, but actually we always work better with support, and I think it's really important we're transparent about that. But yeah, so
Yeah.
I am a specialist physiotherapist. I work only in complex and chronic pain clinic now, and I work psychologically informed by acceptance and commitment therapy. I am currently clinical, so I do 3 days a week of clinical practice as a consultant pain physiotherapist to the OLVG hospital here in central Amsterdam. Central Amsterdam. Amsterdam is tiny. There's only one. It's all central. And in addition to this, I'm an educator for clinicians in pain care science and philosophy. And together with my friend Christine Petridis, I have to talk about Pain Geeks because we run Pain Geeks, which is an international community of clinicians and researchers and people interested in the topic of pain. And we support
Mm.
people to keep up to date, keep their momentum going with their critical reading, and build confidence talking about the challenges and struggles we have in pain care and also the skills that we need to do a better job there as well. Um,
Brilliant.
and I guess the last thing I always say is that I've been training people in acceptance and commitment therapy for about 9 years now.
Mm.
And every year I just get reminded this is not just about what we do with patients, but it's also really helpful for clinicians and their own
Yeah.
well-being. So, yeah.
Yeah, and you're super at delivering that course. I've done it with you, and absolutely
Fun.
fantastic. So we today we're going to be discussing something that every clinician will have felt at some point in their career, and it is the pull to jump in when a patient starts to cry or their voice cracks or they go quiet. The instinct to soothe, fix, or move things along. By the end of this session, you will hopefully understand why that instinct shows up, what it can cost the therapeutic relationship, and how to build your own capacity to sit with a patient's distress instead of managing it away. So this is, as I said earlier, the first session in a three-part series. So if you find today useful, do keep an eye out for the next two. And if you have any questions, please do drop them in the chat, and Laura and I will get to as many of those as we possibly can. At the end of today's session, we are going to be talking about Laura's upcoming ACT course, which starts on the 10th of October. I have already dropped the link to that into the chat, so check it out if you want to. And also, Laura has just written and launched a brand new mini course called Mental Health Risk Assessment and Management. And if you're interested in that, then she's going to be talking a little bit about that at the end. So do hang around and find out more if you're interested. The recording of today's session will be uploaded to Laura's YouTube channel, as I said. Don't forget to go and check out this and other ones and share it with anybody that you think it might be of interest to. We're going to be speaking for about 25 minutes. So we'll kick off straight away with our first question.
Okay.
Laura, when a patient starts to well up or their voice cracks or they go quiet, what is actually happening for clinicians in that moment? And what is it that makes them want to jump in, fix it, and move it along?
Yeah. So, I mean, obviously I can't speak for all clinicians, right? But I think what we often feel is there's sort of two ways that this can sort of go into unhelpful territory, right? And it comes from two different perspectives, but actually what we're doing is probably the same. So we're interrupting the process. So when somebody is having like they're telling you part of their story, it's hitting on a part of emotional distress. They might start to cry or they might start to show you their coping strategies in that moment. So they might be preventing themselves from crying or all the different ways that we're seeing that person behave. I think often what we get drawn to is to sort of interrupting the process, right? So Rolnick and Miller, who created the motivational interviewing framework, they they called this the writing reflex. So it's that sort of urge to soothe or move the distress away or try and fix the problem or switch into solution focused care and solution focused approaches whilst the person is in the middle of the distress.
Mm-hmm.
Um, and there's two ways that this can show up for clinicians, and you have to try and have a think about what this might be for you if you notice yourself doing it. One is that obviously it often comes from this real feeling of genuine compassion, right? You can see somebody is upset in front of you, and you want to somehow let them know that you're there, that you care for them, that you see it. And there's a few ways we do that. We might try and give someone tissues or a glass of water. We might try and hold their hand. We might speak to them. Um, but there's this other reason that sometimes we get urged into this is because we don't feel safe with the
Yeah.
emotion that's on show. So what we're actually doing is self-soothing by interrupting that person's process.
Mm.
Um, and you can even see this sometimes in your practice. You know, someone quiets down, you interrupt, and all of a sudden the moment's kind of gone, and you know you've interrupted something. And I
Mm.
think what's important for us to spend some time with is just thinking, am I moving into this writing reflex? Am I trying to solve or soothe or reduce or diminish somehow this because I think it's the right thing for them, or am I doing it because it's the right thing for me?
Mm.
Um, and I think this is where we have to have like quite an honest conversation with ourselves. Um, because if you are unsafe to hold that emotion, of course it is absolutely fine for you to interrupt it, right? Because you are the person that is holding the therapeutic process. If you are going to be triggered by it in some way, if it's going to harm your mental health in some way, then it might be the best therapeutic choice for you to interrupt that, but it is a therapeutic choice. Yeah.
Mm.
You have to understand the consequences of that. In that moment, um, the opportunity for processing and for release has been lost, and that's okay. That's fine. But we might want to say, look, I can see this is coming up. We're going to refer you to another clinician. I can't hold that part of the process for you very well, yeah, or
Mm.
safely or whatever. Um, and that's okay. And then another part might be, well, how do we get more comfortable at sitting with that distress? How do I regulate myself so that this person can have all of the space in this clinical moment to go through their own process? And that requires us to trust this person as well, that we're going to trust the
Mm.
person in front of us, that they have everything they need to go through that emotional process. They can come out the other end of it.
Mm.
I think this is what's important. I think so often it's very uncomfortable for us, and so we're looking for ways to manage that discomfort. Yeah.
Mm. Could I just this wasn't a question that we pre-agreed, but why is it important to allow the person to finish that process?
Oh, I'm glad you asked that because I think I didn't quite get to that point. So there's a couple of things. Firstly, we are signaling safety. You are
Mm,
safe to have your to be your full human self, right? You don't have to perform being a good patient. You don't have to present in a certain way. You can
mm,
show up in this therapeutic healthcare space and show me what you need. And I am robust enough as a clinician. I am safe enough as a clinician to be in this space with you. Yeah.
mm,
Another thing is that it might be the only place they have to let this out,
yeah.
Like if you think about your own life, your busy life, when you know, we don't have a lot of spaces really to sit and ponder and
Mm,
percolate and consider our own emotional response and let space out, let it sit, let it take up time, right? Time is such a
mm,
what's it like? It's such a finite commodity at the moment. It is the thing that we're all sort of struggling with. That therapy space that you have with them might be the only space that person is allowed
mm,
or gives themselves permission to just feel the feelings rather than
mm,
constantly be moving through, oh, I can't feel this now because I've got to do this, I've got to do that, squashing, squashing, squashing. This is the therapeutic I guess one of the therapeutic roles is being like, no, 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 now we're just going to focus on you, what you need, your feelings, and what's the next step. And if we let somebody feel the feelings, then we can really start to see the impact. And we're going to make much better clinical decisions after
yeah,
that.
yeah.
Yeah.
Brilliant.
Yeah.
Thank you. You explained that really clearly, that and so easy to understand. Thank
Mhm.
you. Um, so what does it actually look like in practice to let let somebody have their feelings without interrupting? Could you walk us through what that might sound like, or how you might do it?
Yeah, so I'd say the thing that we're really aiming for here is co-regulation and safety, right? So we're aiming to give this person space.
Mm,
So I guess the way I would describe that is that I am trying to make myself kind of as small as possible so that they can fill up the room with their emotion. We can see how big this really is. So that might just simply look like me being silent and not jumping in, right? So I
mm,
don't like this idea of like not actions, but it might very often I will simply just sit back and nod and look with my eyes. So I'm not looking away, I'm not looking to this, I'm looking at them and
mm,
just nodding. And then I'm focusing on my own breath. Because if I'm up here, if I'm all here and up, then the energy in the room gets bigger. So I want to make my breath really nice and slow.
mm,
I want to really sort of imagine my body being very heavy. I want to pull the weight of the room down into this slower, lower place so that that person can feel themselves and come down into this space with me
mm.
without me
That's
forcing
interesting.
that through. I think I want to spend a lot of time noticing whether my urges are there and really managing them. And, ultimately, my goal is to validate, not minimize, right? So I want to be like,
Mm,
I can see that you're having a really difficult time right now. I can see this has made you really sad. I feel that you are struggling with this in this moment. You know,
mm,
we're not we're neither confirming nor negating the existence or what the
mm,
cause or any of that. We're just observing the person and confirming to them that this is really hard, that they are doing a good job,
mm,
that these emotions are allowed. Quite often I'll even say to someone, it's okay to cry right now. This is the space for that. Can you stay with it? Can you stay with this feeling? Can you feel it? Um, Especially if I can see that they're trying to push it away. I think
mm.
that's really great moment where you get to sort of support someone and really encourage them to stay with this feeling because that's what they're here
Mm,
for. That's what we're
mm,
working on, the distress and the not knowing and the uncertainty. If I'm not safe to have that, then who is? If not your
yeah,
therapist.
yeah, yeah. So that's fascinating. We are sort of bombarded, I think, socially about this, about the need to feel your feelings.
Mm.
And it's
Yeah,
not a straightforward thing, is it? But because
no.
having somebody there that is actually creating that container for you to express your feelings and
Yeah,
feel through them
yeah,
is quite unique because a lot of humans just simply, as you said before, we want to let people know that we care and we jump
yeah,
in and we do this in daily life. It's not
yeah,
just in the clinic. So that's an absolutely really, really key technique to hear
yeah.
you talk about there.
Now, and I just want to be clear, I'm not saying we don't ever go into problem solving. Right? This is
Mm,
the key thing. The writing reflex is this immediate urge in the moment to make this somehow stop, right?
mm,
Um, whether it comes from that place of compassion because I want this person to know that I am here with them, or whether it comes from this place of I feel distress, so I want to squash it.
mm,
It doesn't really matter. It still has the same impact. It interrupts the process. It takes the process off the person
mm,
once we've moved through the distress, once because it always peaks and drops. Yeah, it
mm,
never stays. It's some and we also want them to want us. I want someone to know that you can feel the depth and the pain of this, and it will drop. It will not stay forever. You can feel it and
mm,
ride it out, and there will be a moment where the intensity of that eases, the sort of the pressure of it lifts, and you can get through that. And
mm,
from an experiential perspective, that person has now just learned something about themselves that is
mm,
very empowering. We talk about agency and self-efficacy. These are not things we tell people to have. These are experiences and confidence and skills that we grow and hold space for. We facilitate them. Every
mm,
time somebody moves through a distressing moment and shows themselves that they can do that, we're building that self-efficacy. I have what I need in order to handle this. Yeah. Even
mm.
if it's
Would
just,
you actually point that out? Would you actually, after
yes.
the peak has
Mm.
subsided, would you actually point that out to the patient and say,
Yeah, I might say, is it subsiding now? Are you finding you've got more space in yourself? Like, you might encourage them to have to observe what's happening in their body
mm,
now. How does
mm,
it feel now compared to before? What did you do in that moment? How did you get yourself through that moment?
mm,
We want
mm.
them to self-reflect and observe that they already have a lot of really good coping skills.
Yeah,
We're not here to teach a blank slate. We're here to help an already successfully thriving, surviving human use their coping skills in ways that helps them in other areas of their life.
yeah,
Um,
yeah.
so yeah.
There's more to this than there isn't there, and
Yeah,
the
of
thing that
course.
always fascinates me about you, Laura, is that and the ACT course and so much of what you do, it is about how to be a human as well as
Yeah,
how to be a clinician, because
yeah.
these skills overlay into our lives as well as in the clinical environment.
It's the same thing, right? A clinician-patient relationship is just a human helping another human with human
Yeah,
stuff. That's really all it is.
yeah,
It's nothing more academic than that. We've got lots of observed frameworks and we've operationalized lots of things that we've seen and observed in other people. And that's what helps us be really good at that job. But ultimately, we're just humans helping humans with human
yeah,
stuff.
yeah. So important to just remind ourselves of that.
Yeah, right.
So just coming on, we've got one more question, and it is that so this can be challenging emotionally for a clinician. And
Yeah.
how do you build capacity to stay regulated and present when patients' distress shows up, and especially when you're dealing with back-to-back patients, and it's a lot, right?
Yeah, yeah, it is.
So
And I think
how do you build up your regulation yourself?
Yeah, I think I might be changing like the way I think about this even as we speak, but like, I think one of the first things that I would say to all people where that are working in healthcare, where therapy is in your job title, and I say this quite a lot because physiotherapy, it's therapy, right? Like, expect it.
Yeah.
The people that are coming into your room are not the people who are like self-managing, have made sense of it, know what to do next. It's the people, there's loads of people out there with probably exactly the same condition that are not presenting into healthcare. What we see are the
Mm.
people who are not knowing what to do next, who are struggling with the thing they're experiencing. Um, so expect it and build it into your model. So if somebody comes in and you're seeing high levels of distress, be prepared to let go of whatever plan you had in that moment
Mm.
and be like, oh, the therapeutic opportunity of dealing with distress has beautifully arrived. This person is giving me the gift of, showing themselves, and
Mm.
I that is much more valuable and offers much more therapeutic potential than anything I could have come up with before they even walked in the room. So
Mm.
this is the moment where we say, well, we're going to pause all of the other plans and we're just going to spend a little moment on sitting with this distress because the skill this person can build in this moment is going to carry over into everything else we do. Yeah,
Mm.
so like expect it and look for it because it's a great moment for you to
Yeah.
do a little bit of really good sort of like skills work with that person and help them believe in themselves when they're feeling
Mm.
vulnerable and like they've lost control and they don't know what the next step is and they're full of uncertainty. You can give them a moment of I've got this.
Mm.
I can do this.
Mm.
Which I think is really, really helpful. And the other thing that I would say, and of course I'm going to say this because I'm an ACT trainer, but really this is where ACT training totally changed my approach to physiotherapy, which is very much this kind of like doing therapy.
Mm.
Um, it encouraged me to go through my own acceptance process, my own willingness to sit with distress and observe
Mm.
why I have confused my role as a therapist with my role of comforting, right? Now, comforting is helpful, but it's not necessarily therapeutic in that moment. So sometimes it helped me decipher that moment of like, oh, this is
Mm.
my job here is in therapeutic support. Um, and not necessarily to get too entangled in that other person's process because
Mm.
they are very sad. They are very distressed. I am not. I am not going through that. I am me. I am sat here with my own stuff. And there is a degree of separation between me and you in that moment, but we can hold this space very well together, and I can support you in what it is that you need, which
Mm.
is to be able to look at your own situation and find out which are the next best steps for you. You can't do that if I
Mm.
keep talking over you and giving you stuff and interrupting it, because all you've got is my voice in your head. And actually, what you need right now is yours. Yeah.
Mm.
So
Yeah.
I think this is
Makes
where
sense.
yeah, I mean it is hard as a clinician to do that. It is absolutely a trainable thing. So if you're sat there thinking, "Oh, I'll never be able to do that," like that's just not. I think this is a very trainable situation. If you understand the process, if you can observe what's happening, if you've got a nice framework, you can put it into play. You can protect you and safeguard your own well-being whilst also giving space for the distress that's happening in the room.
Mm.
This is
Yeah.
absolutely trainable. But I think if you are doing that without training, you might find that it's taking a lot of energy from you because you're giving a lot of your own emotional energy into it. And it might be that that's actually not therapeutically helpful in the moment. That might be what's
Yeah.
actually getting in the way of
Yeah.
and also breaking down the trust between you and your patient. Because if
Mm.
you're jumping in every time somebody else is having a distressing realization about their own very real situation, you
Mm.
might be inadvertently communicating to them, I don't see your distress. I'm not safe
Mm,
for your distress. You are not safe here. Or I
mm,
don't believe it, or I diminish your distress. And that's, of course, not what any of like our clinicians are meaning to communicate, but it could be what's being communicated um,
yeah,
when
yeah, I hear you.
we're actually acting from a place of compassion, but
Mm,
it might not be helpful. And that's the difference between being a therapist in a professional role and being a friend, right? Or a stranger on the street
mm,
that's noticed somebody's upset. You just, that's comfort. That's a comfort role. But
mm,
somebody has contracted with us to be in a therapy role. It's different.
yeah, yeah, I get you. And that takes us really perfectly on to what we to just have a brief conversation about the ACT course. From what I can hear that you've just said there is that this is what actually gave you the confidence, the sort of repetition that actually what you are doing in the clinical setting is right, right, because
Who
there's a
knows?
lot of questioning. You question yourself, all that we all question ourselves all the time, don't we? About
Yeah.
yes, okay, I know I saw Laura's live and she said do this, and
Yeah.
great, that's absolutely fantastic. But then to actually go away and work around this topic and
Yeah.
a whole host of other topics in a group setting and get that validation that actually you are on the right track is a really important thing, and it's where you honed your skills and
Mm.
have perfected them over the years. So, Laura, you have got an ACT course coming up. We're just
Mhm.
going to talk about it for a couple of minutes.
Mhm.
It starts on Saturday, the 10th of October, and it runs across 4 consecutive Saturdays
Yeah.
across the month of October. So, if what Laura started talking about today has resonated with you and you would like to find out more about this approach, Laura, tell us what people tend to get out of coming on this 4 week ACT course.
So every time, like, I think people come in and on the first session, they're like, I just really want to know how to support my patients through this process. It's all very patient directed on that first day. And then at the end of it, the reflection is always, wow, I didn't know how much this would help me in my clinic. And I think that's what I
Mm,
really love about the course that I've been building. And I think I don't know, I'm sure everybody that teaches ACT has the same experience, but like, it is so helpful in safeguarding your own practice because we are being asked to bear witness to distress over and over and over without necessarily being given the skills or the training or validity to that skills and training in our undergraduates, right? So we come out into the world just expected to be able to do it.
mm,
And I think so often we take on the burden because most people in healthcare, we are empathic, we are very compassionate, we are driven towards helping the person in front of us. So much that we've given up Christmases and birthdays and,
mm,
we've nights of sleep, so that we can be there in that role. So, and we take that responsibility really seriously. So the burden of that can sometimes be quite heavy. And I think the one of the things that keeps me motivated to doing the course as a trainer is just how much it impacts on clinicians and their well-being so they can continue to do their job. And that's the
mm.
best source to practice from, right? So, you know, okay, we've done this live and it's lovely and you've got a little bit of a framework, maybe a little bit more language, a bit more permission around distress, which I'm hoping is a great foundation to go from. Um, but the real work is in noticing your distress, how you manage with it. What do you go through? What does it feel like for you to feel it? How long does that take? What's it
Mm,
like when someone interrupts it? What's it like when someone sits with it? Observe your own experiences. Um, because, most people are probably having very similar ones, right? And like we
yeah,
can use that as a way of supporting other people. It doesn't have to be this like academic, theoretical, only patient thing. Your best source of information and clinical growth is probably the capacity to observe yourself. And
yeah,
I think that's what
100%.
just builds all the time. And it is a process. That's why I do it over 4 weeks because I want you to feel the process over time and notice how long that might take and just what kind of an investment that is. It's not an
Mm,
event. It's not something you learn in a
mm,
weekend. Something you do
no.
day in, day out. Yeah.
Thank you, Laura. And you've also just written and literally just launched this morning a brand new mini course on a subject that I think is really, really important and one that doesn't get talked about enough. And
No,
I've just
I'm
dropped the link to that. It is mental health risk assessment and management.
mhm.
Now, it's it's hard to make that title sound, anything more than very functional. But can you tell us really what that course is all about? Because when you told me about it, I was like, the world really needs this.
Yeah, so I think lots of things have sparked this off for me, but we are, I mean, the statistic is sort of ridiculous. It's something like 17 people per day in the UK die by suicide, and only five of
Mm,
them will have ever been in contact with a mental health professional. And
mm,
I reflect on my own practice and just, I mean, how much I focus on mental health and risk and safety in those first few sessions, and then continuously keep maintaining a space for that throughout a person's
mm,
care. Um, and how many patients I have seen that are so affected by when this doesn't go well, you know.
mm,
So I think one of the things that's really important to me personally, as someone who's been through suicidal ideation and depression, and someone who has seen many patients go through that, I think is that it isn't just a psychologist's job or a GP's job. Every person in healthcare that comes into contact with another person,
mm,
we should be aware that these are not people at their best. You know, when they come into healthcare,
mm,
they're not at their most robust. They are very often at their most vulnerable. And these are all the sort of risk, uh, I don't know, I don't know, the risks that we need to be aware of so that we can safely and quickly and
mm,
effectively act. And this is what I talk about when I talk about healthcare justice. Healthcare justice is the right
mm.
clinician at the right time to
Yeah,
promote health.
yeah,
If somebody's coming into your room and they are showing signs of depression, or suicidal ideation, or risk of self-harm, or they're really at the end of their tether, or they're in psychosis, which it happens, right?
yeah,
Um, Health justice is not you doing your therapy session anyway. Health justice is you saying, whoa, you, my fellow human being, you are really struggling in a way that makes me actually a bit worried. And so now I'm going to
mm,
look at the risks that you might be sitting with and then take the appropriate action.
yeah,
Now, if you're not psychology trained, and really want to stress this very clearly, it is not in your scope to intervene on the
mm,
suicidation or the depression or the anxiety or the PTSD or any of those things. It is your job to observe it, know what to do, and effectively hand it over to the right
yeah,
clinician.
yeah,
And that's the key part of this short course and short training is how
yes,
do I effectively, how do I know what I'm looking at?
yeah,
How do I build the right referral or the right handover to the next clinician? What's my next step?
mm, mm,
Um, and how do I go home knowing I've done everything I can for that person? Because you might
yeah.
just have saved a life that day.
That's what you've encapsulated in that mini course. And it's for those reasons that you feel so passionately that all healthcare professionals should have these skills
Yeah.
and that knowledge and that confidence to know what action to take, that you've written it. And also the reason why you've made it really accessible, and financially accessible too. So if you want to go and check that out, I have put the link to that on
Mm.
in the chat. Please click
Yeah.
through. It's a brilliant mini course, and
Mm.
I couldn't think of a better person to have written it than Laura. So
Yeah.
thank you, Laura. Have you got any parting words from today's session? Just a take home?
I think there's two things that I want to say. The first thing I would say is that when it comes to that mini course, if you go online and you think, I really want to do this, but I can't financially afford it at the moment,
Mhm.
even though it is like I don't, it is already quite a reasonable amount. But I think if you think I can't afford it, there is a way of getting 50% off it. And if you still can't afford it, email me, right? Because I just
Yeah,
want people to go through it. I don't
yeah,
necessarily, and then the next thing I would say, about this conversation we've had today, which I think sits quite nicely with the skill set that you need to go through that course, is that
mm,
learning to sit with somebody else's distress will require you to get comfortable with your own.
yeah,
And that's where we as therapists need to be as skilled at our own therapy processes as we are at facilitating them in others.
yeah.
Yeah.
Perfect. Thank
So,
you so much. Thank you,
mhm.
Laura. Oh, I've enjoyed our session today so much, and I hope
Bobby,
that
however,
everybody.
slept all the way through. She's no
I know the dog. He had a little
exception.
turnaround halfway through.
Yeah.
It was just lovely. But thank you for joining us live today, everybody. And we really appreciate your time. And do go and check out the links that I put in the chat. And we'll be back in a couple of weeks, won't we, Laura, with
We
another
will.
session. So hopefully we'll see some of you back then. We really, really appreciate you joining. Thank you again. Take care.
Yeah.
Enjoy the rest of your day. And we'll see you soon.
Yeah. Bye, everyone.
Bye.